Hey, before we start the video, if you like this sort of content and you want more, come check out Med School Bootcamp. We have content for Step 1, Step 2, Anatomy, and OMM. Right now, we're about to watch the Biochemistry section. And if you're looking for downloadable PDFs, along with shorter videos and quizzes after each video to help you reinforce the information, then you can find it all on Med School Bootcamp. We also have a Step 1 question bank with some of the most representative questions to help you prepare for Step 1. You can also create a custom Step 1 study schedule when it's time for dedicated. So if you're looking to crush it in med school this year and pass Step 1, come check out Med School Bootcamp. It's going to be your first link down in the description. Now on to the video.
Hi everyone, my name is Paige and thank you so much for joining me for our chapter on porphyrias. We'll start off in this video by talking about heme synthesis so that you can understand what a porphyria is and the biochemical context from which it arises. And with that conversation of heme synthesis, there are a couple of important side points to address about the regulation of heme synthesis as well as sideroblastic anemia that we'll cover in its own video. And then while there are lots of different types of porphyrias, the two highest yield for your exam and the ones that we'll be covering in this chapter are acute intermittent porphyria and Porphyria cutanea tarda. So let's get started with our lesson on heme synthesis. So what is heme? You're probably familiar with it as a building block of hemoglobin, but it is also a building block of the cytochrome P450 enzymes, which are a large family of enzymes that are important for drug metabolism and detoxification metabolism reactions. So because heme is a building block for both hemoglobin and cytochrome P450 enzymes, heme synthesis will occur in the bone marrow in erythroid precursors for hemoglobin, as well as in the liver in the hepatocytes for cytochrome P450 production. So you can use these uses of the heme building block to back rationalize where they are created. And so this heme building block itself is made up of two subcomponents, a porphyrin and a central iron. And I just introduced another new word. What is a porphyrin? A porphyrin is a heme synthesis intermediate made up of a 4-subunit ring. So let's look at some diagrams, hopefully clarify things a little bit. Okay, so let's take a look. Over here on the right, we have heme. You can see in the middle of the heme is a molecule of iron. And you can see coming off of the iron are these 4 spokes here. Each one of these spokes is supporting a different one of those subunits. Remember, we said the porphyrin is made up of 4 subunits, all arranged in a ring. And so that porphyrin ring and the central iron together make heme. So on the right here, this was heme. On the left here, this is hemoglobin, the oxygen-carrying molecule. And you can see each of these heme building blocks around here, and each of those hemes is surrounded by globins. These are these large, twisty protein globs. So now that you understand what heme is and what porphyrins are, we can go ahead and start talking about the synthetic pathway for heme. Here's the diagram we're working with. I know it's a lot. I'm very visual, so it helps me to see all of these things coming together visually in this way. That being said, don't get too hung up on all of the very specific details about each of these steps. The things to really hammer home are the reactants, intermediates, and products. The names of the enzymes that we'll emphasize. These are the high-yield enzymes. There are others involved in this process. And these regulatory steps, which we'll talk a little bit more on in the next video. All right, so to start off heme synthesis, we are going to start with glycine, the amino acid, as well as succinyl-CoA, which is a TCA cycle intermediate. And these two things will undergo a condensation reaction to become this intermediate called aminolevulinic acid, or ALA. The enzyme that mediates this step is the rate-limiting step for heme synthesis, so very important to know, called ALA synthase. ALA synthase requires a vitamin B6 cofactor, and as is the theme in biochemistry, whenever we have a rate-limiting step, we can identify it as a really easy target for regulating the entirety of a reaction if we focus on regulating that rate-limiting step. As you can see, there are a lot of regulatory players of this step, and we'll talk more about that in the future. Okay, so we did our rate-limiting step with ALA synthase, and we created this aminolevulinic acid, this ALA. Now, if you see our diagram here, each of these little things here is an ALA. We're going to need a lot of ALAs to go about doing heme synthesis. In the next step, we'll take 2 ALAs and an enzyme called ALA dehydratase. We'll go about combining those into something called porphobilinogen. Now, this step isn't necessarily a regulatory target, but is one of the steps in heme synthesis that can be inhibited by lead. Okay, so we're going to run that reaction several times across 8 ALAs. So we're going to combine 4 pairs of ALAs to make 4 porphobilinogens to do our next step. We're going to smash together 4 porphobilinogens via this enzyme here, porphobilinogen deaminase, and we'll form a linear chain of 4 of those porphobilinogens all in a line That is called hydroxymethylbilane, or HMB. Now, like we said, that HMB is linear. So in our next step, what we're going to do is we're going to form our first porphyrin ring. Remember, part of the definition of a porphyrin was it was a ring made up of 4 subunits. So we have our 4 subunits. Now let's go ahead and make our ring. The first iteration of the ring is called Uroporphyrinogen III. And this reaction here is technically a series of reactions, but that is not worth committing to memory. The big representative enzyme to know from this step is called Uroporphyrinogen III synthase. All right, so we have a ring, and in our cartoon, it kind of looks like this, right? We just took our hydroxymethylbilane and we put it in a square. But as you can see, again, in cartoon form, that doesn't quite look like the final form of the porphyrin that we need for heme. So we have to do some other modifications to kind of get there. The first modification, mediated by the enzyme Uroporphyrinogen decarboxylase, is going to form this next intermediate, this next porphyrin, coproporphyrinogen III. So like I said, all of these ringed intermediates qualify as porphyrins, but the final form of porphyrin that we actually like to incorporate into heme is this one, protoporphyrin. We'll do a bunch of reactions to get our coproporphyrinogen III to turn into that protoporphyrin, and so there is our final porphyrin ready for incorporation into heme. To turn the protoporphyrin into heme, remember we have to add that central iron. That was the other component that makes up the final heme molecule. So this enzyme here, ferrochelatase, will go ahead and add that iron into our protoporphyrin, our final porphyrin, and that will form our final heme, our final porphyrin ring, that protoporphyrin with a central iron, as promised. So let's go back to the outline. Remember, our first step of heme synthesis was combining glycine and succinyl-CoA via the enzyme ALA synthase to form ALA, which stood for aminolevulinic acid. That required vitamin B6 as a cofactor. Like we said, that reaction and that enzyme represent the rate-limiting step, which means we need to be on the lookout for regulatory factors. Like I said, I'm going to talk a lot about this in the next video, but your preview here is that this reaction will be upregulated by ethanol as well as cytochrome P450 inducers, and that reaction's activity will be decreased by glucose as well as hemin, which is a synthetic form of heme. Understanding this regulation is very high yield, especially when we go on to talk about some of the porphyrias, which are conditions where heme synthesis is disrupted. Regulating this step is critical for treatment of these disorders. In our next step, we would combine 2 ALAs into porphobolinogen, or PBG, via the enzyme ALA dehydratase. We could take 4 of those PBGs and put them together in a line to form hydroxymethylbilane. And the enzyme that mediated that was porphobolinogen deaminase. Hydroxymethylbilane, over several steps, would turn into Uroporphyrinogen III. I had Uroporphyrinogen III synthase labeled here as one of the enzymes of this step. I would say, though, that one's probably less important to learn. The next step, though, is an important step. It's also a step that's very hard to say out loud. It's where Uroporphyrinogen III turns into coproporphyrinogen III via uroporphyrinogen decarboxylase. And that uroporphyrinogen decarboxylase is also called UROD for short. Once we had our coproporphyrinogen III, we did a bunch of other modifications to turn it into protoporphyrin. And protoporphyrin was that final form of porphyrin that we were ready to incorporate into heme. And in order to make it into heme, we had to add in iron in the middle. And that step was mediated by the enzyme ferrochelatase. And one thing I didn't mention about ferrochelatase is this is the other step that can be inhibited by lead. All right, so that's a lot of intermediates to keep track of. It's hard to keep them all in order, and they all have very complex names. We had glycine and succinyl-CoA turn into ALA, turn into porphobolinogen, turn into HMB, turn into Uroporphyrinogen III, to coproporphyrinogen III, to protoporphyrin, and then into heme. So I did make you guys a mnemonic to help you out. And it is, generally speaking, a patient has unusual chest pain hourly. Easy to remember because it's true. And then the other thing was I used to always mix up the 2 P's. And, it's easy to differentiate the 2 H's because, heme comes last. But I would always mix up porphobolinogen with protoporphyrin. So I always just remember that the protoporphyrin is a pro because it is in its final form ready for incorporation. All right, so let's talk about the clinical implications and why we're even making you memorize all of these intermediates. This is mostly a preview for things that we'll cover over the next couple videos. The first implication of this pathway is with sideroblastic anemia, which can either be a decrease in ALA synthase or in ALA dehydratase activity. Either one of those enzymes affected will lead to sideroblastic anemia. This is characterized as a microcytic anemia with basophilic stippling and ringed sideroblasts. Those are your buzzwords for sideroblastic anemia. We'll talk about what those things mean in the next video, but this can be caused by several things. One from a vitamin B6 deficiency, which makes sense because B6 was the cofactor for ALA synthase. It can be inherited with an X-linked sideroblastic anemia. It can also be caused by alcohol and lead poisoning, both of which we saw have regulatory effects on this pathway, as well as certain medications because of the implication of the cytochrome P450 system in all of this. And the other big clinical implication of this pathway is a family of conditions called porphyrias. And a porphyria is what happens when there's a deficiency in a certain heme synthesis enzyme. And this leads to a buildup of heme synthesis intermediates like porphyrins in usually the liver. There are two big ones to know for the STEP exam, and each of them will have their own video. The first one is called acute intermittent porphyria, and this is a deficiency in PBG deaminase. So if we knock out PBG deaminase in acute intermittent porphyria, we'll get a buildup of some of these upstream intermediates like PBG, porphobilinogen, and ALA. And the buildup of these things leads to a painful abdomen, polyneuropathy, psychological symptoms, as well as a characteristic classic port wine-colored urine. All of the P's associated with AIP. And this is caused by a genetic mutation in combination with a series of triggers. And again, we'll talk more about the regulation of heme synthesis in a future video, but based on these regulatory steps, you can start to guess what some of the triggers might be. Cytochrome P450 inducing medications, alcohol, metabolic stress. And then the other big porphyria is Porphyria cutanea tarda, or PCT. And this is a deficiency in UROD, or Uroporphyrinogen decarboxylase. And so when we knock this out in PCT, we're going to get a buildup upstream of Uroporphyrinogen III. And those uroporphyrins favor deposition in the skin, so they're going to go and build up in the skin and lead to a chronic blistering photosensitivity. And PCT can either be genetic or it can be acquired. So we can either have a genetic mutation or acquired with certain lifestyle factors and other risk factors like sunlight, iron overload, hepatitis C, and smoking. So let's wrap this up. We've been talking about heme synthesis. Heme was our building block of hemoglobin as well as the cytochrome P450 enzymes. And heme was made up of porphyrin, which was a 4-subunit ring that we made as an intermediate of this whole process, alongside a central iron. We talked through the whole synthetic pathway here, and our mnemonic for remembering the intermediates was, generally speaking, a patient has unusual chest pain hourly. Those are the intermediates that are important to know, and we talked about some of the highest yield enzymes like ALA synthase, ALA dehydratase, PBG deaminase, UROD, and Ferrochelatase. And we previewed the rest of the chapter by talking about some of the clinical implications of heme synthesis, like sideroblastic anemia, and two of the highest yield porphyrias, AIP, which was a deficiency in PBG deaminase, as well as PCT, which was a deficiency in UROD. And we did a lot of alluding to the regulation of heme synthesis and all the different things that can interfere with or upregulate this pathway. And that's what we're going to be talking about in our next video, so stay tuned. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige, and thank you so much for joining me for our lesson on heme synthesis, regulation, and sideroblastic anemia. So in the last video on heme synthesis, we talked about the rate-limiting step of heme synthesis, which also happened to be the first step, where we took glycine and succinyl-CoA and turned them into aminolevulinic acid, or ALA, via the enzyme ALA synthase. That ALA synthase enzyme required a vitamin B6 cofactor. We walked through some of the rest of the steps where ALA turned into porphobilinogen via this enzyme ALA dehydratase. And then after porphobilinogen, we did a bunch of other reactions until we eventually formed the porphyrin called protoporphyrin. And then once we had that protoporphyrin, we could combine it with iron. So we could put that iron in the center of the protoporphyrin ring to turn it into heme. And the enzyme that mediated that step was called ferrochelatase. And what we started to talk about in that video is that several of these enzymes have regulating factors. So let's start by talking about the regulation of ALA synthase, that rate-limiting step of this whole process. And then after that, we'll broaden the discussion to include some of these other enzymes and talk about sideroblastic anemia. So ALA synthase, our rate-limiting step of heme synthesis that forms aminolevulinic acid, is going to be upregulated by a few things. First of all, it's going to be upregulated by ethanol. So here's the diagram we used when we talked about ethanol metabolism. Remember, one thing we said that ethanol did is it increases the NADH to NAD plus ratio, right? The metabolism of ethanol into acetaldehyde turns NAD plus into NADH, thereby increasing that ratio. And this ratio is going to trigger the activity of ALA synthase. But why does it do that? Well, remember, I told you that heme is a building block not only for hemoglobin, but also for the cytochrome P450 family of metabolic enzymes. One of those cytochrome P450 enzymes is involved in the metabolism of ethanol, specifically CYP2E1. So the presence of more ethanol in the body, as signaled by an increase in this ratio, is going to signal that we need more cytochrome P2E1 to metabolize that ethanol. And if we want to have enough CYP2E1, we better have enough of its building block, heme. And that's why ethanol and this ratio signal for an increase in ALA synthase activity. And we can take this discussion even beyond ethanol. Any drug that induces cytochrome P450 is going to signal for an increased need for heme. We'll see an increase in hepatic heme turnover as all that heme is incorporated into the cytochrome P450 enzymes. And so cytochrome P450 inducers will also upregulate heme synthesis. And then as you might expect, low heme will also trigger an increase in heme synthesis because your body is saying we better make more. So if you think about it, any of these things that induce the activity of ALA synthase are going to put stress on the heme synthesis pathway. These are signals of increased demand on the heme synthesis pathway. So factors like ethanol and cytochrome P450 inducers, anything that puts stress on this heme synthesis pathway is going to exacerbate porphyrias. Like we started to explain in the last video, porphyrias are a family of conditions marked by deficiencies of some of these heme synthesis enzymes. So for example, if we choose acute intermittent porphyria, which knocks out PBG deaminase, this patient has defective heme synthesis at baseline. Say you add in something like ethanol, all of a sudden now you're putting a ton more stress on this pathway which cannot run appropriately. And so you're going to get a buildup of all these intermediates. It's going to make the symptoms of the porphyria worse. All right, so those are all things that increase ALA synthase activity. What about the things that decrease ALA synthase activity and thereby decrease heme production? The first thing that will decrease this is glucose. Now, the reason why glucose wants to decrease heme synthesis is because, remember, succinyl-CoA is one of these starting reactants. Now, I hate to do it to you, but here's our metabolism map again. And right here is succinyl-CoA. Remember, it is a TCA cycle intermediate. In the presence of high glucose, we're going to run through glycolysis and, in the case of aerobic respiration, run through the TCA cycle. And so running through this cycle is going to decrease the availability of this succinyl-CoA intermediate for other pathways like heme synthesis. So high glucose decreases the availability of succinyl-CoA, and so to compensate for that, glucose will decrease the activity of ALA synthase. The next thing that will downregulate ALA synthase and therefore heme synthesis is a high amount of heme. It's a negative feedback loop to turn off its own synthetic pathway. Similarly, hemin, which is a synthetic form of heme, will also downregulate this step. The only difference between hemin and heme is that hemin has the Fe3+, or the ferric form of iron, in its center as opposed to the Fe2+. And why would we even want to make this in the first place? Well, this synthetic heme is used to treat porphyrias. We'll talk about that more in our videos on porphyrias. And so just like how anything that increased stress on the heme synthesis pathway exacerbated porphyrias, anything that decreases stress on the heme synthesis pathway, so any of these things that we just talked about, are going to mitigate porphyrias. So this is a high yield point. Hemin, that synthetic heme that we can give therapeutically, plus or minus glucose, is a treatment regimen for some of the porphyrias, and we'll talk about that in the future videos. All right, so let's broaden our conversation now beyond just ALA synthase to talk about sideroblastic anemia. Now, sideroblastic anemia is a type of anemia that can happen from a deficiency in a couple of different heme synthesis enzymes. It can happen from a decrease in ALA synthase activity, but it can also come from a decrease in ALA dehydratase activity, which was that next step in heme synthesis, or a decrease in ferrochelatase activity, which was that last step that combined protoporphyrin and iron together to form heme. And the root problematic enzyme is going to depend on the cause or the trigger of the sideroblastic anemia. Things that affect ALA synthase include a vitamin B6 deficiency, because remember, B6 was a cofactor for that enzyme, as well as a genetic condition called X-linked sideroblastic anemia. Now, another thing that can cause sideroblastic anemia by decreasing the effectiveness of that ALA synthase step is actually alcohol. And this, if you take a second to think about it, should be very confusing to you, because I just finished telling you in the last section that ethanol upregulates and increases ALA synthase activity. And now 5 seconds later, here I am telling you that it can cause a sideroblastic anemia, which is caused by a decrease in ALA synthase. Both of those things are true, even though they are at odds with each other. You can either turn your brain off right now, memorize those two facts separately, and go on your merry way, and you would be fine. I will explain to you quickly how both of those things can be true, though. And that is because, yes, while ALA synthase is upregulated by ethanol, another effect of alcohol is a decrease in vitamin B6. Both acute consumption and chronic consumption of alcohol can cause low B6. Even one episode of binge drinking can decrease vitamin B6 absorption from the gut, plus increase its excretion in the urine because alcohol is a diuretic. Not to mention, like we talked about, alcohol increases a whole bunch of hepatic cytochrome P450 enzymes that can affect a lot of different metabolic pathways, including that of vitamin B6. So the attempted increase in ALA synthase activity plus the low B6 leads to extremely dysregulated heme synthesis, and that causes your sideroblastic anemia. And at least if you understand that, at least somewhat intuitively, you're more likely to remember it. All right, so those are things that act on ALA synthase. Things acting at the ALA dehydratase step is really mostly lead. Lead also, though, can decrease ferrochelatase activity. So lead poisoning is really doing double duty here. There are also some medications that can cause sideroblastic anemia. Common ones that they might like to test include isoniazid, the tuberculosis drug, as well as the antibiotic linezolid. And a decrease in copper is also going to decrease ferrochelatase activity. So like we said, there are a lot of both inherited and acquired causes of sideroblastic anemia. As such, it's hard to kind of quantify a one-size-fits-all picture of how to describe sideroblastic anemia. They have different causes, have different ages of onset. Some are microcytic, some are normocytic, some are macrocytic, different risk factors and all of that. But the unifying characteristic is that sideroblastic anemia is an anemia with basophilic stippling and ringed sideroblasts. I'll actually start by talking about ringed sideroblasts. And ringed sideroblasts will be present regardless of whether this is an inherited or an acquired sideroblastic anemia. Basically, in sideroblastic anemia, regardless of what step is knocked out, we're not doing this heme synthesis where we incorporate iron into heme. And so we're going to have this excess iron not incorporated to heme just floating around in the mitochondria. So all that iron is going to lead to a ringed appearance of erythroid precursors. Here's a picture of an erythroid precursor. Remember, immature red blood cells still have a nucleus. And then all these little dots that you're seeing around the outside, those are not normally there. Those are the iron deposits in our ringed sideroblast, the characteristic of sideroblastic anemia. The other thing that you might see in sideroblastic anemia, depending on the cause, is basophilic stippling. This is more common in the acquired forms of sideroblastic anemia, so things associated with exposures. Most classically, this is associated with lead poisoning. Basophilic stippling is caused by residual RNA and ribosomes in the erythrocytes, right? Mature red blood cells shouldn't have either of those things. Like I said, this is mainly associated with lead poisoning due to a decrease in the ribonuclease enzyme that's associated with breaking these things down. That enzyme's inhibited by lead and some of those other exposures. So here's the basophilic stippling in a mature erythrocyte. Remember, in the ringed sideroblast, this was an immature erythroid precursor, right? It still had the nucleus, and we were seeing the iron deposit around the outside. Here, this is a mature red blood cell, but it still has RNA and ribosomes and stuff in it, which it shouldn't. That's a feature of sideroblastic anemia. All right, so let's wrap this up. We've been talking a lot about the regulation of heme synthesis as well as sideroblastic anemia. We said that the rate-limiting step of heme synthesis was mediated by ALA synthase. We said that ALA synthase activity is increased by ethanol and cytochrome P450 inducers and decreased by vitamin B6 deficiency, as well as glucose and heme, which is an artificial form of heme, which would also downregulate this. Anything that increases ALA synthase activity is going to make porphyrias worse, and anything that decreases the stress on this pathway by decreasing that ALA synthase activity will help to mitigate and even treat porphyrias. Then we talked about sideroblastic anemia, which can come from a decrease in the activity of either ALA synthase, ALA dehydratase, or ferrochelatase. There were several different etiologies of sideroblastic anemia. We said one of which, kind of counterintuitively, was alcohol. But really, at the end of the day, alcohol causes dysregulated heme synthesis, and that can lead to a sideroblastic anemia. Other things that cause this include a vitamin B6 deficiency, X-linked sideroblastic anemia, the medications like isoniazid and linezolid, lead poisoning, and low copper. And while the nitty-gritty of sideroblastic anemia can vary a lot depending on what the etiology is, we said the hallmark of sideroblastic anemia was an anemia with ringed sideroblasts caused by iron deposition around the nucleus of an erythroid precursor, as well as potentially some basophilic stippling coming from RNA and ribosomal aggregates in mature erythrocytes. So now that we've clarified some of the regulation of heme synthesis, we can go ahead and move forward with our discussion on porphyrias. What are they? What's going to make them worse? And what can we do to help? So stay tuned for that. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on acute intermittent porphyria. So porphyrias are a family of disorders that are characterized by defective heme synthesis due to defects in specific heme synthesis enzymes. And what this means is heme synthesis intermediates like porphyrins and their precursors will build up in the tissues. So here's our diagram on heme synthesis. Remember, we start with glycine and succinyl-CoA. We do our rate limiting step here with ALA synthase to form ALA, and then in our next step, ALA turns into porphobilinogen. In the next step, mediated by porphobilinogen deaminase, several porphobilinogens will come together in a line to form hydroxymethylbilane. And the enzyme that mediates that step is porphobilinogen deaminase, or PBG deaminase. AIP, or acute intermittent porphyria, which is the type of porphyria that we're talking about in this video, is characterized by an underlying mutation in PBG deaminase. So we're going to get a decrease in the activity of this enzyme. Now, AIP stands for acute intermittent porphyria, and it's characterized by acute attacks precipitated by certain triggers. These triggers are going to be anything that puts stress on the heme synthesis pathway. Anything that upregulates the activity of ALA synthase, the rate-limiting step for this whole process, is going to make the problem worse. Things that put stress on the heme synthesis pathway, and therefore things that can precipitate acute attacks of AIP, include things like ethanol, cytochrome P450 inducers like drugs, and any real metabolic stress. Basically, anything that signals an increased need for heme is going to cause a problem. So any of these triggers can increase the attempted heme synthesis by this pathway, and so we'll increase the formation of ALA and we'll increase the formation of PBG, and then we're going to get stuck right here at this defective step. Can't go through the rest of the pathway. Instead, PBG and ALA are going to build up in the tissues, and that's the pathophys of an AIP attack. Okay, so remember, PBG deaminase mediates the transition from PBG to hydroxymethylbilane. And the pathophys of AIP is that we have an underlying PBG deaminase mutation plus a trigger for an increased demand for heme. So these triggers are cytochrome P450 inducers. And we talked about the rationale for some of these different triggers actually in the last video on heme synthesis regulation. Cytochrome P450 inducing medications will trigger increased heme demand because heme is a building block of those cytochrome P450 enzymes. So things like sulfa drugs, barbiturates, phenytoin, and even smoking are all considered cytochrome P450 inducers that will upregulate ALA synthase. Also, alcohol and metabolic stress can all precipitate an AIP attack in somebody with that underlying PBG deaminase deficiency. So those triggers are signals for increased demand, leading to an increase in attempted heme synthesis pathway activity. But the increase in that attempted synthesis with the decreased PBG deaminase means that we hit a wall and we just end up with a massive buildup of heme synthesis intermediates in the tissues. Namely, in the case of AIP, PBG and ALA are the intermediates that are building up. So AIP will present clinically during a precipitated acute attack, precipitated by one of those triggers we talked about, but they are largely asymptomatic in the interim. Like we said, that buildup of intermediates is not going to be so bad just under normal demand for this pathway. We just run into problems when we really flood the system. And an AIP attack can be kind of tricky to figure out on the test unless you're really sort of consciously remembering this on your differential. It's kind of a bunch of seemingly unrelated symptoms. In the GI system, you're going to see abdominal pain, nausea, vomiting, and constipation. In the neuro system, you're going to see polyneuropathies like paresthesias and paresis, weakness, seizures, and autonomic dysfunction, which includes things like hypertension and tachycardia. These attacks can also be marked by some striking psychiatric findings like agitation, disorientation, and even hallucinations. But the one thing in the stem that they are likely to give you that is really a dead giveaway for AIP in combination with all of these other findings is port wine colored standing urine. So here's a picture. On the left here, normal urine. On the right is the urine of somebody with AIP that's been left to sit on the counter for a few hours. That's standing urine. It'll turn this port wine dark red color. Now it's not blood. Remember, this is standing urine. So it will turn to look like this when you leave it out. So there's a lot of different things and a lot of different systems going on in AIP. The mnemonic to kind of help you remember this is the 5 Ps of AIP. And so the 5 Ps are going to be, this is a precipitated attack. So this comes on acutely. And sometimes in the history, they'll throw you a bone and give you a clue as to what the trigger might have been. Painful abdomen, polyneuropathy, psychiatric symptoms, and this classic port wine colored urine. That's very high yield to know and can help you tell this apart from a lot of other things on your differential. To diagnose this, you get a urine sample from the patient, and most of your clues for diagnosis are going to come clinically, but for a confirmatory test, you can get a urine sample and look for elevated PBG and ALA, those heme synthesis intermediates. For the management here, the obvious thing is to remove the triggers, right? If the patient's on a cytochrome P450 inducing drug, take them off. The other treatment is Heme with or without glucose. Remember, Heme was our synthetic form of heme. It's heme, but with the ferric Fe3+ form of iron in the middle. And when we talked about the regulation of ALA synthase, remember we said Heme as well as glucose both decrease the activity of ALA synthase and therefore of the entirety of the heme synthesis reaction. By decreasing that ALA synthase activity, we decrease the accumulation of porphyrins in the tissues, and that accumulation of porphyrins in all of those different tissues and all those different systems was what was causing our symptoms. So let's talk about a differential diagnosis. I know for me, whenever I encountered a vignette like this, when I was preparing for step 1, I was never ever thinking about AIP. So the first thing you have to make sure is that you have it on your differential. How do we tell this apart though from some of these other things that might come to mind more readily? For one, an acute abdomen. Someone comes in with a bunch of vague symptoms and acute abdominal pain, that's probably what your mind is jumping to. However, you have to look at all the symptoms together. This AIP constellation of symptoms and things like the muscle weakness and the psych hallucinations and all of that, that would be a very unusual presentation for a purely abdominal process. That being said, in real life, when a patient comes in with an acute abdominal pain, you have to make sure you're hitting all of your can't miss surgical emergency diagnoses. All right, the next thing you might mix this up with is alkaptonuria. Remember, when we talked about alkaptonuria in our disorders of protein metabolism chapter, we also talked a lot about standing urine and a change to the urine with standing urine. However, the standing urine in alkaptonuria was black. Not this port wine dark red color. It was actually black. We also saw skin findings like ochronosis, which was the blackening of skin, and then the diagnostics of alkaptonuria involve an increase in urine and serum homogentisate. And you can go check out the video on alkaptonuria if you haven't already to help hammer things down. Next on your differential is the other high-yield porphyria that we'll be talking about in the next video, Porphyria cutanea tarda. It's easy to mix up AIP and PCT, they're both porphyrias, and they're both precipitated by triggers, but the actual clinical presentation of these two things are not super similar. PCT presents with a photosensitive rash. And PCT also has stuff to remember about the urine, but the stuff to remember about the urine in PCT is that the urine will fluoresce on Wood's lamp. We'll talk about this more in the PCT video, but here is an image of the urine of a patient with PCT under Wood's lamp. And you can see it's actually fluorescing this coral color under the lamp. Remember, the discoloration of the urine in AIP was standing urine, and it was just under the normal room lights. You just leave it out on the counter for a little bit. There's no special Wood's lamp or anything to make it do that. The reason why PCT urine fluoresces under Wood's lamp and AIP urine does not is because porphyrin precursors do not fluoresce like porphyrin. Remember, in order for a heme synthesis intermediate to technically be a porphyrin, it has to be this 4-subunit ring. In AIP, the deficient enzyme is PBG deaminase. All the precursors that build up upstream of that, porphobilinogen and ALA, none of those are technically porphyrins, right? None of those are rings. On the other hand, in PCT, the deficient enzyme is UROD, this uroporphyrinogen decarboxylase. So when that's deficient, we get a buildup of uroporphyrinogens, which in fact are porphyrins, and so this will fluoresce under the Wood's lamp. And that's why PCT urine fluoresces and AIP urine does not. And I saved the best for last because this is the one that I struggled with the most as a test taker in terms of narrowing down my differential. Every time I saw a patient where the right answer was AIP, my mind always jumped to lead poisoning instead. Lead poisoning also has this vague constellation of neurologic, psychiatric, and GI symptoms. Someone comes in, altered mental status, abdominal pain, something, vague vignette, you have an instinct that it's a biochem question, but you don't really know what they're asking. Usually when I got a vignette like that, I was like, that's probably lead, and I would move on. I was always forgetting about AIP. Here's the thing about lead poisoning. Lead poisoning can also cause anemia, Remember, we talked about sideroblastic anemia a lot in the last video, and how one of the triggers for it can be lead poisoning. It can also cause lead nephropathy, and while we have this port wine colored urine genitourinary thing going on in AIP, we don't have actually kidney findings. Another thing that they might give you for lead poisoning that they don't always give you, but it's nice when they do, is the Burton line, which is a line of discoloration along the gum line. And then lead poisoning, while it can result in lead nephropathy, does not have any urine changes really associated with that in the same way that we have this port wine colored urine in AIP. That's a big dead giveaway. All right, so let's wrap this up. We've been talking about acute intermittent porphyria, one of the high yield porphyrias, which are a family of disorders of heme synthesis enzymes. The acute attacks of AIP happen in a patient with an underlying PBG deaminase mutation who encounters a trigger for increased heme demand. So anything that upregulates ALA synthase, things like cytochrome P450 inducing medications, alcohol, and metabolic stress. These things trigger the attempted synthesis of heme, but they hit a roadblock when they reach the step of PBG deaminase, and that leads to the buildup of PBG and ALA, those heme synthesis intermediates, in the tissues. And that's across a wide variety of systems throughout the body. And so we used our 5 Ps to help us kind of remember the clinical presentation. It was a precipitated acute attack, resulting in a painful abdomen, polyneuropathy, psych symptoms, and or port wine colored urine. We could measure those heme synthesis intermediates in the urine to confirm, and management involved not only removing the trigger, but also downregulating the heme synthesis pathway by downregulating ALA synthase activity with hemin, with or without glucose. Then we talked through some of our differential diagnoses, perhaps the most confusing of which, at least in my own opinion, is lead poisoning, which shares the neurologic, psychiatric, and GI symptoms, but lead poisoning was one of our causes of sideroblastic anemia and did not result in these urine changes, that port wine colored standing urine, like we saw in AIP. Another thing on our differential was Porphyria, cutanea, tarda, the next Porphyria that we'll talk about in the next video, so stay tuned for that. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on Porphyria, cutanea, tarda. So in the last video, we started talking about the family of disorders called Porphyrias, which are disorders of heme synthesis enzymes that results in a buildup of heme synthesis intermediates, so porphyrins and their precursors, within the tissues. While there are a lot of Porphyrias to cover for the STEP exam, we said there are 2 big ones. The first one we covered in the last video was AIP, and PCT, Porphyria, cutanea, tarda, is the other big one, and that's what we're talking about in this video. So here was our heme synthesis pathway. You've seen this many times by now. We started with glycine and succinyl-CoA, and we went through the pathway until we got to here, this step where Uroporphyrinogen III turns into coproporphyrinogen III via this enzyme UROD, or uroporphyrinogen decarboxylase. PCT is characterized by a defect in UROD, either an inherited defect or an acquired defect. And this decrease in UROD can either be inherited or it can be triggered and acquired. We'll talk about those triggers when we get back to the outline, but the point is we are blocking off heme synthesis right here at this step, and we're going to get a buildup of uroporphyrinogens in specifically the skin. That's where these things like to accumulate. So under normal circumstances, uroporphyrinogen III will turn into coproporphyrinogen III via this UROD enzyme, uroporphyrinogen decarboxylase. When we have a decrease in UROD, either inherited or acquired, we're going to get a buildup of those uroporphyrinogens in the skin, like uroporphyrinogen III. And there are other types of uroporphyrinogens off of side pathways here that we didn't cover, nor should you for the STEP exam. But all those uroporphyrinogens together, represented by the one you need to know, which is uroporphyrinogen III, will accumulate in the skin. And that'll cause some of the symptoms that we'll talk about in a minute. So like we said, this can be inherited or acquired. An inherited deficiency should be pretty self-explanatory, but what are ways that you can acquire this? There are several different risk factors that decrease UROD activity and interfere with this pathway. These include sunlight, iron overload, so patients with hemochromatosis. Sometimes in the vignette, all they'll give you is a patient with a history of hemochromatosis, right? So a history of iron overload. And it may seem like it has nothing to do with the question at all, but they're giving you the risk factor. Alcohol can also trigger this, as can hepatitis C, right? The liver is a major site of heme synthesis, so any of these things, alcohol, hepatitis, can affect this heme synthesis in the liver. So what is the clinical presentation of PCT? A blistering photosensitive rash on the dorsum of the hands, the face, neck, and sun-exposed skin is really the hallmark of this disease. This is the thing to really hammer home. So these are the hands of a patient with PCT, and the dorsum of the hands is very commonly commonly a sun-exposed area. Same thing with, for example, the face. And you can see this really painful blistering rash. Like we said, this can happen in any area, especially the heavily sun-exposed areas like the face, but really the dorsum of the hand should be the buzzwords, the red flags going off in your head for PCT. I really want you to lock down this image. They'll either give it to you or they'll describe it to you very commonly. Other things you might see include skin hyperpigmentation, sclerosis, hypertrichosis or excessive hair growth, and then you may also see tea-colored urine. This is different from the port wine-colored, really deep red urine that we saw in AIP. This would be more brown, and tea-colored urine is not specific for PCT. It can be a number of things. To diagnose this, you can check porphyrins either in the serum or in the urine, and these will be elevated. And then the other thing that you might see or they might describe is pink fluorescence of the urine under Wood's lamp. So here's a picture of a cup of urine underneath the Wood's lamp, which is this UV lamp. It looks like a black light. And here you can see a coral red fluorescence of the urine of a patient with PCT. Remember, we're seeing a buildup of uroporphyrinogens. Uroporphyrinogen is a porphyrin. It was one of those heme synthesis intermediates in a ring structure. Those porphyrins fluoresce under Wood's lamp. And so this urine fluorescence under Wood's lamp is characteristic of porphyrins accumulating in the urine. To manage PCT, first, of course, you're going to avoid triggers. So avoiding sun, avoiding alcohol, things like that. You can also use hydroxychloroquine to treat. And one thing you can do if a patient is very symptomatic and is iron overloaded, right? For example, in a patient who has hemochromatosis, is you can do phlebotomy to phlebotomize off some of that iron. So let's talk now about differential diagnosis. First thing on the differential, which is a real consideration in real life, but on the STEP exam, I doubt they're going to test you on, but you might see it as a wrong answer, is pseudoporphyria. Pseudoporphyria will show a similar blistering pattern to PCT, but without the porphyrin accumulation. And pseudoporphyria will also be triggered, but other than UV light, the triggers are entirely different. Commonly, NSAIDs and dialysis are the big triggers for pseudoporphyria. Again, be really 100% sure if you're going to pick pseudoporphyria over PCT on the test. This is going to be like a trap answer for people who studied too hard, but worth considering in real life. The next thing that might be on your differential is bullous pemphigoid. Bullous pemphigoid, also a blistering disease. However, the blisters in bullous pemphigoid are going to be tense bullae, whereas the ones you see in PCT are these fragile blisters on the dorsum of the hand. Bullous pemphigoid is generally going to have a later age of onset. This tends to happen in the elderly, and it more commonly happens on the legs as opposed to the hands and face. And if you were to test a patient with bullous pemphigoid for porphyrins, those would not be elevated. Now in step 1, there are lots of blistering rashes. So another one you might be thinking about is epidermolysis bullosa. Epidermolysis bullosa has a much earlier age of onset. You'll see this more commonly in a young child, and this is blistering with minimal trauma. So a trauma-induced rash, even minimally so, as opposed to the photosensitive rash of PCT. Next thing you might be thinking of, especially if this patient with PCT comes in with a photosensitive rash, especially on their face, is lupus. And yes, lupus does present with photosensitivity in the pattern of a malar rash, so a rash across the nose and cheeks that spares the nasolabial fold. However, with lupus, there are widespread systemic symptoms. I could do a whole video on all the different ways that lupus can present. But the point is, it's not just the rash. You're going to have a lot of other clues that point you towards lupus. You'll have the positive ANA as well as the anti-DS DNA, right? These are the rheumatologic markers of lupus that we're not going to see in a non-rheumatologic disease like PCT. And again, in lupus, no porphyrins on serum or urine testing. And finally, it's easy to mix up your porphyrias, so you might have AIP on your differential, especially if you see that tea-colored urine, you might get them mixed up. However, remember, AIP presents with port wine-colored urine, which I showed you a picture of in the last video. And the urine of AIP does not fluoresce under Wood's lamp. That's because in AIP, the defective enzyme is upstream of any true porphyrins, right? We get the buildup of plenty of heme synthesis intermediates, but none of them are porphyrins in the ring. And that means that they don't fluoresce under the Wood's lamp. And then in AIP, we also had a variety of other systems that were affected: abdominal pain, neuropathy, and psychiatric manifestations, to name a few. So let's wrap this up. We've been talking about PCT. PCT is the most common porphyria, and as such is the most commonly tested porphyria on the Step 1 exam, so it's an important one to know. It is a deficiency in the Uroporphyrinogen decarboxylase enzyme, or UROD. It can either be inherited or acquired, and it leads to a buildup of porphyrins, specifically uroporphyrinogen, in the skin. Susceptibility factors for this include sunlight, Iron overload is very high yield, like hemochromatosis, alcohol, and hepatitis C. PCT presents with a blistering photosensitive rash, classically on the dorsum of the hands, but they may also describe findings on the face, neck, or really any sun-exposed skin. Remember, because sunlight was a precipitating factor. To diagnose this, we looked for urine and serum porphyrins, as well as pink fluorescence of the urine, or really that coral color, under the Woods lamp. We managed this by trigger and sun avoidance, hydroxychloroquine, as well as phlebotomizing off excess iron as necessary. And we talked through our differential diagnosis, which mostly included other blistering disorders, as well as lupus and AIP. And that's all I have for you for this chapter. If you have any questions, comments, concerns, problems, troubles, worries, hopes, dreams, fears, send them on my way. Otherwise, good job, good luck, and keep practicing. All right, go ahead, take a minute, read through this question. Feel free to pause if you need more time. This is a long one, and then we will come back together to talk about the answer. So I'll walk you through our long stem in a minute, but just to sort of prime you for all of this, the correct answer is F, toxic accumulation of heme synthesis intermediates. This is a patient with severe cramping, abdominal pain, nausea, constipation, mild peripheral neuropathy, confusion, and dark-colored urine that darkens on standing. This is all classic for acute intermittent porphyria. And the trigger in this case is carbamazepine, which is a cytochrome P450 inducing drug. And cytochrome P450 inducers increase the activity of ALA synthase, leading to the accumulation of toxic downstream intermediates in the heme synthesis pathway, like ALA and PBG. All right, so let's read through the stem and figure out how we got there. So we have a 24-year-old woman, and she's coming to the clinic with severe cramping, abdominal pain, nausea, and constipation for the last 5 days. And she's had similar in the past, triggered by stress, but she's saying that this is more intense. So if I were to stop reading the question right there and you were to ask me for a diagnosis, I would say IBS, or irritable bowel syndrome, seems reasonable. She's having constipation and abdominal discomfort, and it's triggered by stress. That all lines up. However, this patient is having mild paresthesias in her fingertips that usually accompany her symptoms. That does not align with IBS. And I put that in red because that should be setting off alarm bells. So I personally am starting to doubt this diagnosis of IBS, because why would she be having paresthesias? She has a history of bipolar disorder as well as the IBS, and her medications include loperamide and carbamazepine, which she initiated 2 weeks ago from a prior regimen of valproate. So anytime you see a timeline for a recently initiated drug, you should lock in on it. Our patient is having 5 days of symptoms, and she changed her medications 2 weeks ago. And carbamazepine I also highlighted in red because that is one of those drugs that when you come across it in a question, you should come to a screeching halt. Carbamazepine is very commonly tested in the context of adverse drug effects. And we'll talk about that when we walk through our incorrect answer choices. And part of the reason why carbamazepine is so commonly tested is because in addition to having its own characteristic adverse effects, it also interacts with a lot of other drugs via the cytochrome P450 system. So the cytochrome P450 enzyme family is in charge of metabolism of not every drug, but a lot of drugs. A cytochrome P450 inducer will increase the activity of cytochrome P450 and increase drug metabolism, and a cytochrome P450 inhibitor will decrease the activity of cytochrome P450 and will slow down drug metabolism. So there's lots of space for drug-drug interactions when you're dealing with cytochrome P450 inducers and inhibitors. In my opinion, the cytochrome P450 inducers that are the most important to remember is this list right here, probably in order from most important to least important. I would say rifampin, carbamazepine, phenytoin, barbiturates, sulfonamides, and then griseofulvin. Our patient switched from a cytochrome P450 inhibiting drug, which was valproate, to a cytochrome P450 inducing drug, which was carbamazepine. And that was just 2 weeks ago. Now, if she just had run-of-the-mill IBS, that wouldn't really matter so much. Because cytochrome P450 doesn't really affect loperamide, which is the other medication on our list, all that much. But if her stress-induced GI symptoms and neurological symptoms, or paresthesias, are not just run-of-the-mill IBS, which, spoiler alert, they're not, and the back half of the question will also help confirm this for you, then this is worth revisiting. So let's finish reading the question here. Her vital signs are within normal limits, other than mild tachycardia. On physical exam, her abdomen is diffusely tender, without rebound, guarding, or rigidity. There are no skin changes. So the physician is going to diagnose her with a severe IBS flare and prescribe hyoscyamine, which is an anticholinergic medication that can be used to help with abdominal pain and cramping. And then they are going to continue her home medications. And I'm putting that in red. That's another red flag of ours. They're going out of their way to tell you that they did not stop the offending medication, or this red flag hot button medication, carbamazepine, that had set off alarm bells for us earlier. Then over the next 24 hours, her symptoms are going to worsen, and she's going to get confusion, neuropathic, she's going to develop hyporeflexia and muscle weakness, and urinalysis is revealing dark-colored standing urine with otherwise normal results. So 2 things about that UA. One is that dark-colored standing urine. That standing urine is a huge buzzword. That's urine that gets dark when you leave it out on the counter. And then we also know that we have otherwise normal results. We know that this dark urine is not from blood or myoglobin, which is normally sort of the smoking gun for dark urine. So we have a patient with pain, polyneuropathy, psychological disturbances, now as this sort of proceeds to get worse. Port wine colored urine could be how you maybe describe this urine that's getting darker. And it was precipitated by changing to a famously offending medication, carbamazepine, a cytochrome P450 inducer. Those are our 5 Ps of acute intermittent porphyria, AIP. So acute intermittent porphyria, or AIP, is caused by an underlying problem with this enzyme porphyrin deaminase. So here we have our diagram of heme synthesis and how we're creating the heme that goes into hemoglobin. We can see all the different enzymatic steps of the process that go into making heme, and in acute intermittent porphyria, there is a defect in porphyrin deaminase. So acute intermittent porphyria presents with acute intermittent attacks of those 5 Ps I talked about earlier. And the acute intermittent nature is because the AIP attacks are triggered by increased heme demand, right? Demanding more on this heme synthesis pathway. So cytochrome P450 inducers are one of the things that can trigger these AIP attacks by increasing the rate of the rate-limiting step of heme synthesis. Alcohol is another trigger, other drugs are also triggers, and increased metabolic stress, including illness, can also trigger this. So the increased demand causes increased attempted heme synthesis. But that increased attempted heme synthesis in combination with that defective PBG deaminase enzyme that we see in AIP will lead to buildups of toxic intermediates like ALA and PBG. That's what causes those symptoms. So our correct answer is F, toxic accumulation of heme synthesis intermediates. That is the pathophys of the symptomatology in AIP. Let's talk about our incorrect answers. Answer choice A is anticholinergic medication excess. In this case, in this question, the anticholinergic medication was hyoscyamine. So we would be worried about a hyoscyamine excess. So you would have chosen this answer if you thought that she was indeed having an IBS flare. We gave her too much hyoscyamine, and then all of those symptoms that happened after the fact were the fault of the hyoscyamine, as opposed to a progression of her chief complaint. So the cholinergic system, in my head, represents the rest and digest parasympathetic side of things. So an anticholinergic medication in excess will cause sort of a sympathetic overdose. That's kind of how I think about it. So an anticholinergic overdose is going to have a classic ultrasympathetic toxidrome. And there's a mnemonic here. So there's hot as a hair, which is hyperthermia, dry as a bone, which is going to be dry skin and dry mouth, red as a beet, which is flushed skin, blind as a bat, which is getting at mydriasis, also known as dilated pupils. And this can lead to some blurry vision, and mad as a hatter, which is hallucinations and delirium. But you'll notice these characteristic findings do not include dark urine, and they also don't include neuropathic symptoms like those paresthesias. So I don't think it's an anticholinergic overdose, and so I'm going to rule out this answer choice. And again, from the beginning, we were concerned that this wasn't just normal IBS because she had those paresthesias to start out with. So I'm less convinced that it was just this medication that we gave that caused the problem. I think this has been going on from the beginning. Answer choice B is drug-mediated acute muscle breakdown. This is representing rhabdomyolysis, and we know that this isn't the case because we knew that the urinalysis didn't have any myoglobin in it. We were told that other than the dark standing urine, we had normal results. If you didn't know that, you could have worked around by noticing that none of the other medications in the stem really cause rhabdo. We already talked about the adverse effect profile of hyoscyamine. Loperamide is pretty benign. It mostly just causes constipation, maybe some nausea and vomiting. And while carbamazepine can cause a lot of adverse effects, rhabdo usually isn't one of them. Carbamazepine, we're more looking at CNS toxicity, maybe things like diplopia, ataxia. We can see bone marrow suppression, so we can see an aplastic anemia or agranulocytosis. We can see a drug rash, so things like Stevens-Johnson syndrome, or occasionally we can see SIADH, syndrome of inappropriate ADH. So even if you didn't necessarily pick up on the normal UA, if you knew the side effect profiles of the medications in the stem, you knew that this probably wasn't the right answer either. Answer choice C represents serotonin syndrome. This presents with autonomic instability, things like hyperthermia, tachycardia, diaphoresis, neuromuscular hyperactivity, so things like hyperreflexia and clonus, and altered mental status. Now we know that our patient was hyporeflexic, not hyperreflexic, and that's kind of a strike against this. And also there are no serotonergic medications in the stem. Drugs that make me worry about serotonin syndrome are usually in the psych family, specifically antidepressants, things that try and boost systemic serotonin like SSRIs, SNRIs, TCAs, MAO inhibitors, some anti-migraine medications like triptans, linezolid, the antibiotic, can also do it, and then some illicit drugs like MDMA, or else supplements like St. John's wort. If you haven't encountered any of these drugs yet, it's okay, you'll get there in due time. Just giving you another way that you could put this answer choice lower on your preference list. Answer choice D, functional dysregulation of bowel motility. This is IBS. We debunked this already. I won't belabor this point. The neuropathy of her symptoms is uncommon, and that second part of the question, none of those symptoms are a normal sequela of IBS. This is out. Answer choice E, heavy metal toxicity. You could be worried about lead poisoning in this case, and I will grant you that a lot of the symptoms of lead poisoning do overlap with AIP. Some of the symptoms of this case are characteristic of lead poisoning. Things like the severe abdominal pain, the neuropathic symptoms, the confusion, those are symptoms of lead poisoning. It's not a bad thought. But lead poisoning is usually chronic, and it usually doesn't present acutely with a rapid worsening like this. It wouldn't follow this episodic flares type of picture. Additionally, that urine that darkens on standing is not characteristic of lead poisoning. That is AIP, that screams that AIP buzzword at you. So E is out. So, in summary, this patient's abdominal pain, polyneuropathy, psychiatric disturbance, port wine colored urine that darkens on standing, and precipitated attacks of these symptoms is characteristic of acute intermittent porphyria or AIP. This is triggered by carbamazepine, which is a cytochrome P450 inducer that increases ALA synthase activity as part of the heme synthesis pathway. That increased demand on the heme synthesis pathway in conjunction with an underlying defective enzyme in heme synthesis, PBG deaminase, leads to a buildup of toxic heme synthesis intermediates like ALA and PBG. And although this patient was initially misdiagnosed with IBS, some of the red flags that I'm sure you picked up on included the paresthesias in her fingertips and the recent change to that hot button medication, carbamazepine. And that's all I got for you. Good job, good luck, and keep practicing.